Thank you very much. I'm absolutely thrilled to have been invited to be here, so thank you very much for that. I should have a caveat really, that although I've just been introduced as an expert in this, actually the caveat is that maybe there isn't an easy solution, and perhaps our data might suggest that at the end. So many of you probably don't know who I am. I'm an advanced neonatal nurse practitioner, and a very brief introduction into what that is. For those of you that work in the UK, you'll probably know all about us because we get everywhere. But generally we're nurses that have done extra training, and we work on the medical rotas generally in most centres in the UK. So I work on the neonatal registrar rota, so I put in central lines, and I think that's important when we're identifying what some of the barriers are to that. So I know where we're all coming from. But I also access lines in the same way that the nurses would do as well. And because one job wasn't quite enough for me, I also work at the University of Southampton, where I work as a teaching fellow, and I teach neonatal nurses how to be nurse practitioners. So I've got a dual role. Southampton is at the bottom of the UK there, which incidentally is the 19th happiest country in the world. So in a very British way, we're sort of happy, but maybe not quite happy. We're maybe less happy at the moment than we have been in the past. And because two jobs wasn't enough for me, I'm also in the final year of doing my PhD. And I'm looking at how we implement practice change on the neonatal unit, but specifically relating to how we prevent infections. So that's a bit about me. And I just want to thank my supervisors who've got me to here today, and the Royal College of Nursing Foundation, who have covered some of my PhD fees for me, which is very kind of them. And I was going to start this session by talking to you all about the numbers. And I was going to talk to you about the statistics of what the impact of these infections are on our babies. But in the spirit of this being an online forum that started up online, I woke up to this tweet this morning, which was actually precipitated by some debate about high flow from Brett's sessions yesterday, but actually relates quite nicely to this. And this is from Professor Paul Clark, who is a neonatologist in the UK. And he has said that actually here was a baby, an extremely low birth weight baby, who was actually very happy on high flow, despite the lack of evidence, until she developed a central line related infection with coagulase negative staphylococcus at 2 weeks of age. And the important thing about this is that I think for a long time we've thought that these infections are fairly harmless. They're skin commensals, they're probably mostly contaminants, but there is an increasing body of evidence that suggests that these do impact potentially on long-term neurodevelopmental outcome. Paul Clark has written up this case with the permission of the parents. There's some quite shocking photos in there as well. And she went on to have PVL, periventricular leukomalacia, and actually has a degree of cognitive disability as well. So they're probably not as harmless as we first thought they were. So I'm not going to really talk about increased mortality and morbidity, because I think that photo has probably said it all for us. But there was a recent point prevalence survey across Europe that was published in The Lancet fairly recently that looked at 770 paediatric hospital-acquired infections. And they found that 45% of them were bloodstream infections. And they also found that you were at increased risk of having a hospital-acquired infection if you were a neonate, if you had one or more invasive medical devices, and if you had an increased length of stay greater than 14 days. And I think we can probably all say that our babies have all of those things probably, and definitely stay longer than 14 days. And late onset sepsis also increases your length of stay as a neonate, and that can be anywhere from 4 to 7 days, but it can also be potentially as long as 30 days. And that's a significant amount of time to be in hospital. And with that comes along increased healthcare costs. We don't really want to talk about money, but it's important. And potentially, the evidence, there isn't a lot out there, but these central line associated bloodstream infections can cost anything from $6,000 to $12,000 per episode. And in the UK, the National Institute for Clinical Excellence has suggested this is probably about £10,000. Some really conservative work that I did on our own unit suggested that we could reduce costs by over £200,000 if we reduced our infection rates. And that is a phenomenal amount of money. It could buy some of that fancy technology out there, but it could also fund some extra nurses or lots of other things you could do with that money. And there is a global health priority in reducing antibiotic resistance. I'm not going to talk about that because that might come up later. But we have to treat these infections once the baby has them with antibiotics, and there is increasing antibiotic resistance, so we should be trying to minimise that. And a colleague of mine yesterday asked me, how was I defining the problem? So how was I defining a central line associated bloodstream infection, or a CLABSI, because that's much easier to say. And that's really difficult, and it's really variable, but it's really important. So if I convince you to go and read any paper from today, this would probably be the one. This was a quality improvement study run across 19 centres in New York, so it was a massive project. And they wanted to implement a care bundle, which I'm going to talk about for the rest of the talk really, across all of these centres. And each red dot is one of the 19 centres in New York. These are all tertiary neonatal intensive care units. And these are their CLABSI rates. But halfway through their project, the Centre for Disease Control changed the definition of what a CLABSI was. So the top line, or the top set of data, is the pre-intervention data with the old definition. And at the bottom, you have the pre-intervention data, so the same set of data, but with the new definition from 2009. And the definition changed to, if you had a Cons infection or a skin commensal, you needed to have isolated it on 2 separate occasions for it to count. There's some nods, that's good. And what they found is that just applying that definition changed their CLABSI rate by 40%. They reduced their infection rate by 40% just by applying a new definition. And you can see that there's some centres here, this one here, and possibly also this one here, that go from about 14 per 1,000 central line days down to about 4. So it does make a real difference. So what can we do about it? Well, this is really the focus of my research, so it is primarily what I'm going to focus on today, which is care bundles. And these have been used in all sorts of different settings, haven't they? They've been used to prevent ventilator-associated pneumonia. There's a small amount of evidence that potentially it can help reduce NEC rates. And what is a care bundle? It is an intervention with multiple interacting components. So we're not just introducing one thing into practice, we're introducing lots of things that we think might work and that we think that they interact in some way. And many of you will have heard of the Michigan project that was run out of the US by Peter Pronovost. And this was held as a massive success. And this really kind of propelled care bundles aimed at reducing CLABSIs into the forefront, really, of the evidence. And they reported a massive success. They reduced their CLABSI rates by 70%. And that was sustained over a 3-year period. And they're still now reporting rates of less than 1 per 1,000 central line days. And we attempted to replicate that in the UK, not me personally. I wasn't involved. But we introduced Matching Michigan into a lot of UK intensive care units. You should note that this was done in adult ITU, so not neonatal. And the problem really with the Matching Michigan project was that it failed to outperform the secular trend. So it was a stepwise cluster study. So some centres, before they even entered the study, were already starting to reduce their infection rates, which meant that they couldn't say with any certainty that they'd outperformed the secular trend. They did find 48% reductions in paediatric rates, and I would love it if we could have those rates locally, but that didn't reach statistical significance. You can argue whether or not that's important. So these are the 5 core components. These are the 5 core components that the CDC recommend should be in central line care bundles. Now, these are the ones that the CDC think are probably have the least barriers to implementation and are most likely to have the greatest impact. And I think as neonatologists there, you can already see that there is potentially some issues with some of them. So we'd be 100% compliant with avoiding the femoral site because we don't do that at all locally. We don't use that site. Cleaning the skin with chlorhexidine and alcohol might be controversial in some of the really extreme preterm infants. And I'm sure that there are some people here that don't really want to wear full maximal standard barrier precautions in an incubator at 80% humidity and 37 degrees, but maybe that's controversial. And then alongside that, they introduced what we call professional elements. So these are things that we think might help the implementation of those 5 along the side. So these are things like having a catheter insertion cart, or having a checklist for insertion, and empowering nurses to stop the process if they think there's been any breaches. And Mary Dixon Woods, who has published a lot about quality improvement work, and I would advocate you go and read her papers, wanted to really try and understand what was happening in these 2 different studies. So they were introducing the same things into practice and were getting very different results. And we've talked a lot already today about variations. And so she went back to Michigan and she did a retrospective study. And she decided that the centres were all starting to look the same. So they were starting to change their processes and their structures and their ways of doing things. So they were starting to look like each other, and that's called institutional isomorphism. And you can do that through coercion. You can do that by saying these are things you have to be compliant with, and we're going to audit you and we're going to measure your compliance. Or you can do that by starting to share the same values and the same beliefs and the same ethics and starting to change your culture. So in Michigan, it was hailed as a huge success in changing culture. They introduced things like checklists that were seen as a form of social control. It increased visibility of the way we do things here. This is our practice. This is the standard that we expect. And it reduced, and I really like this term, it reduced the concept of social loafing. And that is the concept that in a group, some people will do less because they know that there are others who will kind of carry them through. And I can see some smiles, so some people obviously know some people like that. Enough about that. But in the UK, it didn't at all have the same impact. I wasn't involved in any of this work in the UK, but from the qualitative ethnographic study that was run alongside it, they found that actually staff couldn't see, not in all centres, some centres really did embrace the programme, but some centres didn't see that the practices were any different. What's the difference this is going to make? We're already doing this already. So what happened is it didn't really change the culture of some of these units. It failed to change the status quo, professional relationships that went unchallenged, the ones that perhaps were less beneficial. And they also found that the implementation of checklists wasn't as they intended them to be, and that's quite important. So, right, over to you. Do you have a central line care bundle in your neonatal unit? Yes or no? We're going to start with an easy one answer question. Oh, this is not jumping up as quickly as it has in the past. Obviously some discussion about this. Get the phones out. Oh, oh. 80%. That is actually much higher than I thought it would be. The next question that I should ask, which I haven't, but the next question I would ask of you is, do you know if your staff are using it as you think they're using it? Because it perhaps might not be. So I'm going to talk you through the evidence really for this particular practice that many of us now seem to be doing. And so we really wanted to try and improve our infection rates locally. So we thought the first thing we should do, being evidence-based, is we should go and see if these bundles are actually effective in neonates. They've been kind of purported to be good in other populations. So we also wanted to know if they were effective, what should we include in them? There's a whole host of things that we could put in them. So what should we do? So we did a systematic review and a meta-analysis, and I'm not going to go through the methods of that because it's published and you can go away and read that, light reading. But what we found is there were 24 quasi-experimental studies. So there were no randomized control trials. I think it might potentially be quite hard to random half of the babies on your unit to a care bundle and half not. And they were all quasi-experimental. So some said they were observational, but really they were all, this was our pre-intervention data, we introduced this bundle, and this was our post-intervention data. It was across a variety of settings, so developed and developing countries. And overall, there was a 60% rate reduction in the risk of CLABSIs if you introduced a care bundle. And that seems quite significant. There's some caveats to that, because nothing is ever that easy, which I'll talk you through. And that's a forest plot. Now, you saw a lot of them yesterday, so I'm not going to talk through how to interpret one of these, but the black diamond on the right-hand side does not cross the line of 1, of no difference. So we could conclude, if we wanted to, that care bundles are going to statistically be significant in reducing your CLABSI rates. We should point out here that these were not randomized controlled trials. They should not really, from a methodologically purist point of view, be put into a meta-analysis. But I think it gives a nice overview of what the data is that's out there and what it's telling us. And because that's now almost 2 years old already, I thought I'd better see what else is out there since 2017. And there are several more studies to suggest that yes, these bundles do reduce infections. There have been not a single negative study fully published in the literature. So I'm going to talk about publication bias in the next couple of slides. So there is definitely evidence out there. So before I tell you what they did, I'm going to ask you, what do you do? 80% of you have got a care bundle. Do you use full maximal standard barrier precautions when you're putting in a central line? Do you use hat, mask, gloves and gowns? Do you do that for everybody? Do you do that only if they're in an open cot? So do you not do that if they're in an incubator? Do you use sterile gloves and gowns only, so you forgo the hat and mask? Do you not do that at all? Do you do something completely different? Oh, wow, that is interesting. Either that or you think that that's the right answer, I don't know. Again, I would urge you to all go back to your units and see what actually happens. Wow, interesting, okay. Good, I guess. I think we don't know, but okay. Next one. So, when you're cleaning the skin of a tiny preterm baby before you put in a line, what do you use to clean it with? Do you use chlorhexidine in aqueous solution? Chlorhexidine with alcohol? Betadine or iodine? Combination based on gestational age, as arbitrary as that might be? Or something else? And if it's something else, do tell me. Some chitter-chatter. No, a bit more mixed. Okay, that's interesting. I'm going to talk about some of the evidence for some of those things in a few slides' time. And finally, I can't be a nurse and not ask any questions about dressings. I'm obsessed with central line dressings. So when do you change them on your unit? Do you have a policy in place for when you change your lines? Do you do it only if the line is exposed? Do you do it routinely every 7 days, regardless of what the condition of the dressing is? Oh. Do you do it after 24 hours following insertion? If it's bloodstained or peeling or something else? I'm enjoying the chatter. This is good. Oh, this is taking a little bit longer, isn't it? People aren't sure about this. This is certainly reassuring me about my practice and what we're doing locally. Okay, that's interesting. Well, we're going to find out what these studies said they did. So this looks like quite a busy slide, but really it's to show the variation of what is happening in the care bundle studies that we found. So this is the 24 studies along the top here. These are the authors. Some of you might be here. You can offer some insights. And then the technical elements, which are the things that they're doing with the lines at the bedside, are the ones that are shaded in the bluey grey colour. And what we call the professional elements, the things that might help implementation and help people do what we would like them to do, are the kind of beige colour. And I should say here that we didn't contact, in our review, we didn't contact any of the authors for any of the original data. So they might be doing things that they just didn't report. So that's quite important because we won't have captured that. And you can see that there's quite a lot of variation there. The top reported technical interventions would be to use maximal standard barrier precautions, by which they meant a full hat, masks, gloves, gowns. Having a dedicated skin preparation protocol was top of the list, and assessing the need for the line on a daily basis. And some centres said that they did that in a really interesting way. They were on a ward round and they said to themselves, or the nurse or the parents, if we didn't have a central line in today, would we put one in? And if the answer was no, they took it out. Now, locally, for me, that would probably be quite a change in mindset to what we currently do. But that's what they said they did. And 100% of studies said they educated and trained their staff. Brilliant. That sounds like a really good step. And then the next common ones were having a multidisciplinary team to engage with the project, to design the project, to help implement the project, providing audit and feedback to staff about infection rates. So telling staff what your infection rates are might be useful, and the introduction of a checklist. But it's not that easy, because it never is it? Actually, within some of these elements, there was massive variation. So the skin preparation protocol, some used chlorhexidine with alcohol, some used betadine, and 23% didn't tell me or tell us what they used. So it's a bit difficult to know. And the same with central line dressing protocols. Papers have said that they had a protocol in place, but some of them said they changed them every 7 days. Some said they only changed them if they needed to. And a couple of centres used chlorhexidine impregnated dressings. And education and training was also not done kind of consistently. Some used simulation training, some used video training, and some used kind of webinars to kind of reach other centres in their networks. And the variation continues, unfortunately. The extent of the effect was different across all the centres. So baseline rates ranged from anything as low as 1.3. I would love it if our unit got to those rates. And post-intervention, some centres finished with rates that were higher than others started with. So I can't stand here and tell you exactly how much you're going to reduce your rates by, unfortunately. Sorry, don't leave, stay. And it's really important to point out right now that 25% of neonatal intensive care units in America are reporting 0 rates. So that's a quarter of tertiary centres in America. And I appreciate that they have a different healthcare system, particularly to us in the UK, but I think that that's really important, and I think that we need to see these things as being preventable. But we all want to know what happens in the subgroups. We talked about this a lot yesterday, but what is the data in the subgroups? And this again, unfortunately, is also not clear. So not all studies, only a handful of studies tried to look at the data for the subgroups. Oh. And they found that some studies found that they couldn't sustain reductions in the really smallest of babies. So in the 750 gram babies, they couldn't keep those reductions over time. But another study said, that's not our problem. Our problem is we can't find reductions sustained over time in the 1,000 to 1,500 group. And I think you can probably all know what's coming next. Another study said, actually, we can't find sustained reductions in the group over 1,500 grams, which leaves us in a bit of a quandary about what to do. And again, going back to the New York study, which I talked about earlier, they had one centre that made a massive impact. This was hailed as like a flagship centre. They reduced their infection rates, their CLABSI rates, by 96%, implementing these bundled procedures or processes. But the same study that was meant to be implementing the same set of practices in the same way increased their rates by 187%. You can see the argument that I'm trying to sell you all, that it isn't, we do need to know about the technical components, but we also need to know about the culture. And a lot of the studies actually concluded that even when they had adjusted their data for differences in centre, they still found significant variations. So you might say, well, we don't have surgical babies, or we don't have the extremely low birth weight infants. Maybe that explains it. Actually, even when you've adjusted for that, there are still centre-to-centre variation. Oh. So site of care remains an independent risk factor, which I think is probably not acceptable, but part of life. And a lot of the authors concluded that actually when you've seen one neonatal unit, all you've seen is one neonatal unit, because we are all different, we all practice things differently, we all have variations in the way we do things. And so studying the practice patterns of these neonatal units that report really good outcomes for all sorts of different things, including things like BPD, could be useful. Risks of bias, I couldn't not talk about these. I've talked about that these papers shouldn't probably really have been put into a meta-analysis, but there is probably a strong risk of publication bias here. I think as a local unit, if you'd implemented something and it didn't make a difference, you're probably not going to go out and try and get that published. So conference abstracts were excluded because we couldn't really get enough data out of them on what the intervention was. But there was one negative conference abstract from a group in Luton in the United Kingdom called Mismatching Michigan. A very clever title. And they actually doubled their infection rates after implementing the Michigan Care Bundle. But 2 years later, they published a different set of data, again, another poster presentation, that said, actually, we didn't fully implement all the care bundle elements the first time round. So we've gone back and we've fully implemented all the bundled elements, and now our rates are back down to where they were before. So they're back down to where we started. And what is great about research, so we published our findings and we got a letter about the risk of detection bias, which was great because it made us go back to our data and have another look at the studies that we'd reviewed. And we hadn't really thought about this, or at least put it in the paper at the time. And you could argue, couldn't you, that if part of your intervention is to remove central lines if they're no longer needed, in the post-intervention group, you should be at less risk of having an infection because you've reduced the amount of central line days that you have because you're taking your lines out. So we went back to the data and we found that in 16 studies, they assessed whether or not the line was needed. So we went back and looked at those 16 studies, but only 53% of them actually had reduced, well, 53% of them had increased central line days after the intervention, which doesn't really make sense, but it likely, again, reflects variations in practice. And so that's interesting. So some centres increased their central line days by 17%, up to about 713%. So there was, again, quite a lot of variation. And just of note, I didn't talk about this earlier, but I'm sure that this might be a question that people might ask me. Only 5 studies reported when they took their lines out. So 5 studies out of 24 said that they took their lines out when they reached 120 mils per kilo per day of enteral feed. One further study said that they took their lines out when they reached 150 mils per kilo per day of feed. They don't say what that feed is or what their nutritional outcomes really are. So there are other things, aren't there, other than those things that were on that slide earlier, that might potentially reduce infection rates. on your unit. So do you do any of the following? Do you use alcohol impregnated caps? They might be called swab caps or Kuros caps, depending on where you work. Do you use chlorhexidine impregnated dressings? Or do you use antibiotic impregnated central lines? Or do you do none of them? Right, that is interesting, but actually very good. When you look at the evidence, 68% of you might be quite pleased that you voted that way. So the group from the Netherlands that published quite a lot of work about this as well have recently done a systematic review looking at alcohol impregnated port protectors. They did find in the studies that were out there that was a 31% reduction in risk, with a confidence interval that didn't cross the line of no difference, so a statistically significant result. However, this is again a selection of observational evidence. It is a small amount of studies. There's only one neonatal study. They do a funnel plot and say that the results are asymmetrical, so there is likely to be publication bias. And what they do is they urge any of you out there that are using these to publish your data, regardless of what quality it is, so that we can get some idea of the gap. And there was a bench study that found what they call a concerning amount of alcohol potentially being injected into the lines when you screw them on to the end of your central lines. And for that reason, the group in the Netherlands have not recommended these for use in neonates without further research, which is slightly worrying when I show you what I'm about to show you. But they do say that actually what these caps might do, these alcohol impregnated caps, is improve nurses' work and improve the way they perform tasks on the unit. What else might help? Potentially antibiotic stewardship. That's the real driver in the UK now. We're trying really hard, I think, to reduce the amount of antibiotics we give for early onset sepsis. And there's some recent work, and this is really tentative, but they have found an association between every extra additional day that you give antibiotics for presumed but blood culture negative early onset sepsis in the first 14 days and an increased risk of late onset sepsis later on. So potentially if we reduce antibiotics that are unnecessary or not needed, then potentially we might reduce our late onset sepsis rates. Sam Oddy and his team in the UK recently have completed the PREVAIL study, which isn't published yet, but they have presented the results at some conferences. This was using rifampicin and meconazole impregnated central lines or central catheters produced by Vigon. They found no difference in their catheter-related infection rates between the two groups, a rate of 10.2 and 10.7% bloodstream infection rates, I think. And they don't recommend that they be used in practice. They did find an increasing amount of antibiotic resistance in the isolates that they found. So it's good that people said they didn't use them. And what we should clean the skin with before we put in these lines. Kieran et al. In 2018 have published some work looking at iodine versus chlorhexidine and alcohol, and they again found no difference between the two, but they did find an increasing amount of thyroid dysfunction in the babies that had iodine and that required treating with thyroxine. And Professor Paul Clark out in Norfolk and Norwich in the UK is currently undertaking the Arctic study. I'm not sure what the acronym stands for, but they are looking at using chlorhexidine in aqueous solution or chlorhexidine in alcohol. So that might help us decide which one of those we should use, particularly in our really tiny babies that are at risk of skin burns. So there's still a lot that we don't know, sorry. Thanks for sticking with me. There is a lot of uncertainty, I think, as to what we should be putting into the bundles, what are the things that are going to have the biggest impact for the least amount of effort, I guess. And the evidence base for some of those individual elements is limited. For example, chlorhexidine impregnated dressings, I think there's probably only about 2 studies out there and they're quite small. And what we really don't know, cue some future research, is whether or not the intervention is effective, or whether or not there is something to do with the implementation that is important, or if it is a combination of both. The fact that we can introduce the same set of practices into different units and have different results suggests that potentially there is something else going on. And unfortunately, it is unlikely that you're going to introduce a checklist and that is magically going to solve all of your bloodstream infection problems. There were over 100 different versions of the Michigan checklist, and Peter Provenost, who ran that study in the US, has recently, well, in the past year or so, been interviewed on a podcast. So those of you that like your podcasts, you can go and have a listen. And he says that actually, whilst compliance is important and we should audit practice and see what people are doing, actually it is unlikely to be the thing that's really going to help. What we should be doing is trying to understand what is going to make things easier for our staff to perform the things that we want them to do or know that they should do. We know, for example, that hand hygiene is the most effective way to prevent the spread of infection, and yet we know that hand hygiene compliance is poor generally in the literature. So what can we do to make it easier for our staff? So we need to get the technical components right. We need to know what interventions work. Absolutely we do. We need the science. But we also need to know the cultural things. We need to know what's going on our unit. And what we're thinking now is that actually, certainly in the American study, CLABSIs are being seen as a social problem. And by that I mean two things. One, it is a problem that is solvable. This is a problem that can be solved. And secondly, it's a problem that has a behavioural solution. So we can solve this by changing behaviour. And we used to think that if we targeted individuals' attitudes, it would change their behaviour. If we educated people in a classroom and said, this is what you should do, go and do it, we thought that that might work. But we're moving away from that now. We're seeing it as a sociological problem, really, because of two reasons. So the theory of planned behaviour is based on the assumption that human beings are rational. I'm not rational at 3 in the morning when I've been up all night and I haven't eaten. And it also is based on the assumption that our values and our beliefs don't change. And I think, if we're being honest, we probably know that in different social groups, perhaps our values and our beliefs and our attitudes do change. So that's important. We also know that healthcare is being seen now as a complex adaptive system, by which I mean it is unpredictable and it's not linear. So if you introduce change into a complex adaptive system and you expect it A to cause B, that actually might not happen, or it might happen but not in any way like you imagined it would. So this is our data since 2016. Wouldn't it be fabulous if we'd presented this in February? When it would look like we had had our best rates in at least 3 or 4 years. We've got some data in 2015 as well, but it's presented as quarters, not as months. So I still need to unpick all of that. But actually we have never, ever had rates this low. This was 0 rates for 2 months. But I can tell you that March isn't going to be great either, because I've been on the unit and I've worked there. So I know that we're definitely not going to have 0 in March. So this is what we've been doing, for what it's worth, I guess. We, in 2015, led by one of our consultant neonatologists, we set up a multidisciplinary team. That's what the evidence says we should do. So we did it. We had nurse practitioners, we had microbiologists, we had consultants and infection control nurses to try and determine what we should do and what we should implement in practice. We told the nurses that they should be accessing their lines in a sterile manner, so using surgical non-touch technique. We told the medics that they should be using 2 people to put in a central line and fill out a checklist. And then we introduced some late onset sepsis guidance, which really looked at antibiotic stewardship, as well as how to change your central line dressings. And then we introduced alcohol impregnated caps, despite what I've just told you. And maybe convincingly, this is better than previously, but I don't think you can say with any certainty that we've really made any difference. So what's going on culturally is probably quite important. This is where I was doing my first phase of data collection. If I told you, I know that I'm running out of time, but if I told you that 50% of my data collection, which is observing practice, happened here, that might be interesting, mightn't it? So I'm doing a mixed method study. I've almost finished the first phase of data collection. I have done surveys of staff, which is quantitative, to look at implementation. And I'm observing practice with consent. All of the staff have had to, well, they don't have to. 60% of staff have agreed and been consented to be involved. So I'm observing practice with interviews afterwards, and then I'm going to interview people in more depth later on. And very, very quickly, this is really preliminary. I'm in the dredges of qualitative data analysis at the moment, but I've been let out to come here, which is nice. The nurses really valued the changes, so we've asked them to do something that takes longer and needs more staff, and yet they love it and they will do it. So they will change their central line infusions in a sterile surgical technique way, and they will use the Kuros caps because they think it makes life easier for them. It makes it easier for them to change practice or to challenge practice, and it provides a sort of ritual that they really like. So despite that, they have incorporated that into practice. But inserting central lines hasn't developed the same set of rules or changed the culture in the same way. Some of that is possibly because we have doctors that rotate every 6 months, and they have to come and try and incorporate their previous experience and their previous way of doing things to try and fit in to what we're asking them to do. And they say that they're doing things differently but achieving the same result. They also say that no one's ever told them that their line has ever had an infection. So why should they change what they're doing? Actually, it's very difficult to attribute a central line infection to one particular person. And there's quite clearly delineated roles. The nurses talk about things that are their work, and the medics talk about things that the nurses can help with, but then the nurses can go and do their own work. And so who's got the overall responsibility for looking after these lines? And obviously there's barriers, which I'm still analysing, but the medics and the nurse practitioners that put in lines talk about, I've got so many things to do, I've got 100 jobs to do, I just need to get this line in and then get on with my other jobs. So how much of a priority they are, I'm not sure. So in summary, there is quite a large body of evidence now to suggest that care bundles can reduce your infection rates, but there's still a lot that we don't know. And I want to just leave you finally with this quote that I stumbled upon last week that summarised exactly how I felt, which is that change is unpredictable, it's hard won, it takes a lot of time, it's very often tortuous, and it needs to be tailored to your local context. And that's it. Thank you, and sorry for going over.